Hello?
Halo, halo, halo.
Again, I can on. Are you all of you all around, or we are just few of us? I see 16 people. How many of you are around? Yeah. How many people are attending? Are you getting me or not?
Yeah, they are lecture.
Let's continue what we have started. We are talking about myeloproliferative disorder. We have spoken about the three forms: chronic myeloid leukemia and primary myelofibrosis. Okay, myeloproliferative myoplasma. They usually carry elevated red blood cells masses. So we have one category B. The difference is just in one of the category B, it involved with the white cell, but also increase of vitamin B12. The both category may also splenomegaly. So when you have someone with a polycythemia, which usually response of tissue hypoxemia, they have aspect of renal disease, which may be associated with increased erythropoietin production. You may also have dehydration. If someone is dehydrated, when there is body. So quickly on the review for myeloproliferative symptom neoplasma, we have Philadelphia positive, which is with the tyrosine kinase activity involved in chronic myeloid leukemia. We have a Philadelphia negative. Among them, we have the one we call JAK2, which will be positive in 85% of polycythemia rubra vera, 50 to 70% of essential thrombocythemia, but also 50 to 60 in case of primary myelofibrosis. When JAK2 is negative, we have either polycythemia rubra vera. We can also have essential thrombocythemia. But again, you have to check for other mutation, which also may describe the polycythemia myelofibrosis. So that JAK2 is Janus kinase, which has also a tyrosine kinase activity, which is involved in the signal transduction of erythropoietin receptor by also expressing that gene. So it's make by stimulating the tyrosine kinase activity that may make the cell to proliferate in controlled way. Uh, that is the issue for now. So JAK2 mutation again, it's a single nucleotide in JAK2 mutation where the valine is replaced with the phenylalanine on the codon 617. Then the mutation is usually occur in pseudokinase, which which has again the activity of tyrosine kinase. Then we have said that it's present in 50 to 70% of essential thrombocythemia. So, a polycythemia rubra vera, the JAK2 is present around 90%. So, it's somehow common compared to other myeloproliferative disorder. Occur above 60 years. Then it's somehow more common in men compared to the female. It's lower in Japanese than in US and Europe. A study across Nigeria showed that polycythemia rubra vera can be around 0.5%. Again, radiation exposure to toxin. There also somehow family history of JAK2 mutation may also raise the disease progression. Manifestation is just by understanding if someone has a blood volume high, hematocrit high, hemoglobin, he will be having future of hyperviscosities, which is manifested by headache, dizziness, visual disturbance, pruritus, and so on. Then among the complication, again, hyperviscosity, there will be tendency to have stasis, so there will be high risk of getting thrombosis, but also there might be bleeding and erythromelalgia, having some bone diffuse pain. So sometimes the patient may be asymptomatic than just going by the checkup. You may see the patient having a polycythemia. There is a study which was also seeing a gastroduodenal lesion in polycythemia rubra vera, but also they found that the H. pylori infection and polycythemia rubra vera was somehow independent risk factor for GI lesions. So having a polycythemia rubra vera, it look like it may also increase risk of having gastroduodenal lesions. The other sign may have gout arthritis, ophthalmic manifestation, skin exposure to discoloration and so on. It is not common. So how do you make the diagnosis? The diagnosis is just made in the full blood count where you check the hematocrit. It will be elevated above 49 in men, then above 48% in female. Have splenomegaly. But again, this is like a myeloproliferative disorder. It may also associated with increase of platelets, increase of leukocyte. This is the full blood count, hemoglobin level, the white cell count, and the platelets. So as you said, sometimes it may be associated with increase of other parameters of be turnover of the cell with the cell destruction, or there will be increase of uric acid and so on. So how do you make the diagnosis of how do you differentiate primary polycythemia to secondary polycythemia? It's just to understand the mechanism of the disease. So let's say for primary one, meaning that there will be increased production of red cells. By increased production of the red cell, there will be the hemoglobin will be transporting oxygen to the tissue, so there will be good oxygen supply. So there will be feedback on erythropoietin synthesis. So there will be tendency to have decreased erythropoietin level. But for secondary polycythemia, again, this will be generally due to hypoxia. So there will be chronic hypoxia with chronic stimulation of erythropoietin synthesis. So there will be increase of erythropoietin. So that's how you can make the difference between primary and secondary one. So low erythropoietin level, which is highly specific to polycythemia vera vera. So you see the patient with the high hemoglobin, high hematocrit, but he has low erythropoietin level. There will be high red cell mass, and you should also predict when you see the count above 18 per gram, hemoglobin of 18.5 gram per deciliter, or 16 gram per deciliter in female. So there will be also endogenous erythroid colony formation. There will be increase of erythroid precursors in the bone marrow. The full blood count, when you look on the blood smear, you see the red blood cell are normocytic, normochromic. It may be also hypochromic microcytic in case there's association with iron deficiency when the patient is bleeding, because you said that among the complication, they might also have future of bleeding if happen. There's high risk of thrombosis, to having thrombosis, as it's somehow raising from the myeloid precursor. So patient may have also association of thrombosis, but also they may have leukocytosis. We have said that polycythemia vera vera may also transform to myelofibrosis. So when there is a transformation to myelofibrosis, you may see dacryocyte, which is teardrops, the red cell which look like teardrops. You have a variation in shape, or you may also see neglected red cells. So again, those cells are immature, are mature compared to the acute one. So in polycythemia vera vera, despite that the leukocytes are mature. So when you go to the bone marrow, you will see that there will be vascularity for the edge. Then there will be prominent growth in erythroid, granulocyte, and megakaryocytic proliferation. This is the disease somehow progressing. We have uh, initial stage, we have a polycythemic stage, and we have terminal stage. So from the beginning, the patient will come here. They may have splenomegaly. Then progressively, they may also progress to fibrosis. Then from the fibrosis, we say that fibrosis among the fibrotic patient, that may develop to blastic crisis, but also from the polycythemia ribravir, 10 to 15 may also progress to acute leukemia. Uh, Chromosome abnormality have been reported in 20% of the polycythemia vera, where they said that there might be duplication of the chromosome 1, then again, we have to do molecular studies by searching for Jack, which should be like a feature of confirming the diagnosis. So this is the MRI of a patient who has sagittal sinus thrombosis without any of venous effusion or mass lesion. So just the patient may have thrombosis due to hyperviscosity, where the stagnation of the blood through the vessels, which is a risk of lymphedema in right area. The tablet, which is just saying how when do you suspect polycythemia ribra vera and what to do. So what you have the elements supporting the diagnostic of polycythemia ribra vera. You see leukocytosis, thrombocytosis, splenomegaly. You go for checking for erythropoietin. JAK2 is said positive around 90%. So if JAK2 is positive, what granulocyte and megakaryocyte proliferation. But again, so this is the criteria of definition. Kenshi, differential diagnosis. We have JAK2 mutation positive, which is can be as myeloproliferative myeloplasma. Among them, we have essential thrombocythemia and primary myelofibrosis. But also remember other cause of polycythemia, which can be due to either excess of the tumor, renal tumor producing erythropoietin, or secondary to chronic hypoxemia. So that is the summary to know which is primary or secondary one. So when you have a polycythemia, primary one, erythropoietin will be decreased. or normal, you confirm your polycythemia vera vera. Secondary erythropoietin will be increased at either hypoxia driven in case of high altitude or cardiovascular diseases, then hypoxia independent, which can be either renal cyst or tumor or extrarenal tumors, which may also produce some increase of erythropoietin. So those are just people doing their athletics. Some of them also may use uh, so so we also about hypoxia independent. So it's not only hypoxia driven one, but there are other causes. So again, the primary erythrocytosis should be considering the age of the patient. We said that it's really coming above age of 50 most of time, but also you have to screen for the underlying condition. I remember some years back we had an old man like 55 years, almost 60 years, I think. He used to have a polycythemia for a long time. They classify him like primary, so they told him that he's having a polycythemia rubra vera, but also he could not even measure for JAK2. We have sent him for heart evaluation, lungs evaluation to see if there's any chronic hypoxia explaining why the patient is having erythrocytosis. We could not find any, but one of the senior cardiologists from a visiting cardiologist who came, he did a special cardiac ultrasound and found that the patient was having right left shunt. So that was which was congenital, so it was not diagnosed before, but just were focusing on the age of the patient, saying that he's an old man, that's probably primary. So remember, some people may have congenital disease at that age, which is somehow misdiagnosed. So that patient was found to have secondary, which was thought to be. So when you look on the two images, we have polycythemia rubra vera and secondary erythrocytosis. So in A we have reactive, which is secondary erythrocytosis, but in B we have polycythemia rubra vera. What do you see as difference? Compare the first one. This one, the first image is secondary, and the B is polycythemia rubra vera. What is the difference? Do you see the difference between the two images, or you don't see any difference? Any difference? So on the first images, you see there is on the second image we have prominent increase of erythrocytosis, of other cells, which usually even the granulopoiesis is stimulated. This is a megakaryocyte, the large cell here, which is prominent. It is increase in the megakaryocyte. But the first one, you see that there's just somehow a normal bone marrow, which is just producing normal cells. So here we have also increased production of the precursor of the white cells and the platelet together. So, how is the treatment? Who can tell us the principle of the treatment? Someone with polycythemia, how do you treat it? How do you treat him? We can guess it. Who can guess how to treat polycythemia? Anyone can guess how to treat it? Sorry, I didn't get you.
I think it is having frequent blood.
Hmm? You think?
Mm, it is it is having frequent blood withdrawals.
It's up?
Having frequent blood withdrawal.
So there'll be what we call phlebotomy, repeated phlebotomy to get up to the having the normal hemoglobin, normal hematocrit. So the goal of treatment is to minimize clinical, physical, and laboratory features, and to minimize the long-term complication, which includes thrombotic events, myelofibrosis, and malignancy. And it is a balance between controlling the diseases and the treatment complication. So usually they say that there is no drug which improve the survival or lower the risk of leukemic transformation or polycythemia vera. So whatever you treat it, the risk of transforming to leukemia is still there. You can't change it. Then the mainstay of the therapy is to do phlebotomy, and the aim is to targeting hemoglobin below hematocrit below 45 in male and among 42 in female. So by doing repeated phlebotomy. So when the phlebotomy alone, it's not working, but also you have to assess the risk of the patient to have thrombosis. It's when you'll be discussing starting of hydroxyurea, which will be targeting to decrease the cell count quickly and decrease the rate of phlebotomy. So that is the you remember that even the chemotherapy has side effects, but it's been shown that just by giving phlebotomy, you can see better survival time compared to give chlorambucil basic, because those chemotherapy can also raise the risk of developing cancers in the past. So it really the survival time is low compared to flip. So that's why we didn't give someone those hydroxyurea. You have to assess the age of the patient. Is if he's younger than 60%, you try phlebotomy. You see how it responds. When it is not responding, that's when you decide to go for further chemotherapy. But also, if the patient is having high risk of thrombosis, again, you have to consider giving those chemotherapy as said. So if it is treated, the prognosis is somehow 6 to 18 months from the time of the diagnosis. But if it's treated, the survival time may go to 13 years or even more. And the mortality rate is around 3.7 death per 100 person per year. So the most of complication which may kill your patient is especially thrombosis, risk of hematological malignancy. We have non-hematological malignancy which are there. We have hemorrhage, but also myelofibrosis. The bad prognosis is associated with the advanced age, associated with the leukocytosis, history of venous thrombosis or abnormal karyotype. So again, this help you to understand the risk of the patient and to decide which treatment to start on the patient. So again, this is the major survival was like now it is somehow improving compared to the last some years back. So I think that was all about myeloproliferative disorder. If you have any question, you can ask before we continue. Any question? If there's no question, let's continue. So a little word on iron overload. We have seen that iron deficiency cause anemia, but now let's also consider iron overload. So iron overload is the status. We have said that the normal adult total body iron is around 5.5 grams per kg. have 5 gram, but we talk about iron overload when it really increase out to 20 to 30 gram. However, we have said also that there is no physiological mechanism to excrete the excess of iron in the body. So that's iron accumulation. It might be either where there is an excess of iron absorption or again chronic blood transfusion. So we have seen people on repeated blood transfusion. That's one, but also we have a behavior where we see someone with anemia, we rush to put him on iron therapy. So every patient, most of the doctor, when they see anemia, they put on iron without even knowing is it iron deficiency, is not iron deficiency. Most of them are in the district hospital. They cannot and they cannot test for iron studies. So they put most of the people blindly on iron therapy, where when they transfuse, then they give you iron therapy. They expose you to have iron overload. So when there's iron overload, there'll be risk of iron accumulation on the different organs like pancreas, causing diabetes. It may cause deposition on the endocrine glands, on the thyroid, on the liver, and so on the heart, causing myocardiomyopathy, and so on. So now let's say due to increased iron absorption in case of hereditary hemochromatosis, which is a autosomal recessive disorder. It's usually accorded by the human hemochromatosis protein, which is called FHFA protein, which is located in the FA and accorded by FA gene on the chromosome 6. The mutation is there, then it may cause increased iron absorption. But also in case of inactive erythropoiesis, we have said that 75% of iron is supposed to go for erythropoiesis. When there is a thalassemia, there is any cause of inactive secondary, apart being the increased iron absorption, they have also increased iron intake, especially in the African siderosis, which the decrease was either due to diet, but also there are some genetic factors which was uh, who have been described to be associated with increased iron or iron overload. Secondly, we have said about repeated blood transfusion. Avoid unnecessary blood transfusion, but also remember iron chelation when you are giving chronic blood transfusion to one of your patients. Hemochromatosis, which is a autosomal recessive disorder, which is again characterized by this gene, where there is a tyrosine residue is replaced by cysteine on that mutation. Then it's usually a disease which is not here in Africa. It's rare in Africa, more common in European population. It's commonest among people above 50 to 70, and it's more male to female, ratio of 5 to 1. So in this pathology, there'll be parenchyma iron loading with the parenchyma iron deposition, which leads to organ dysfunction. So there'll be multiple organs involved in this. If there is a deposition of iron on the heart, there'll be cardiomyopathy. The patient may have a future of heart failure, dyslipidemia, and so on. It may go to the retardation of the sexual development in the pancreas, causing diabetes, on the liver, causing cirrhosis, and so on. So any organs can be affected in case of hemochromatosis. Secondly, we have to consider doing a laboratory test which confirm the diagnostic of the iron overload. We have iron to be higher, serum transferrin will be high, saturation will be high, but also ferritin will be very high. Increase iron in the liver, increase iron in the on the bone marrow. So let's go now to how do we treat iron overload. First of all, we said that if someone is bleeding, is also decreasing the iron. So the principle of the management will be focusing on regular venesection. Each unit, which made 250 mil, will be removing around 200 and 250 milligram of iron. So when you are doing a phlebotomy or venesection, you need to do regular control of iron studies. You can also associate iron chelation therapy, which is focusing on giving desferrioxamine at that dose, which can be given subcutaneously to 5 to 7 days. Then you recheck the iron. It usually excreted in the urine, but you can also see in the stool. It may have some side effects. Then you have to monitor those side effects. You can also give dysferriprona, which is also given in case of iron overload, but it can be given together with the first medication to make some synergy on the treatment. But the key is to do phlebotomy or venesection. In Africa, we say that the prevalence of hemochromatosis is not high, it's very low, but the African has somehow they have African dietary iron overload, which was described in 1953 in the South African as Batu siderosis. So it was postulated that this iron overload is mostly due to high consumption of iron in their drinks. So there is a tradition of drinks used to prepare in the South Africa, which they were using a beer cooked in steel drums. So there were also speculation that it might be not only due to high consumption of iron, but it might be due to any other genetic predisposition which is different from the one seen in hemochromatosis. So the prevalence of this African iron overload was around 20 per 200 people, especially in rural areas where they used to consume this traditional beer. So for this pathology, there was really hepatic iron concentration, which was associated with the African iron overloads. There's also accumulation of iron both in the macrophages, but also in the parenchyma of the hepatic, which was in contrast of hemochromatosis, which was only parenchyma iron overload. So the clinical manifestations are the same as the previous one, having a iron.
Mommy.
Stop disturbing. Sorry for disturbing. Let me share the slide again. So the symptoms are the same, but also the management plan will be the same. So regular phlebotomy was very effective. plus ion chelation as the one see previously, but they were somehow revising the technique of cooking, preparing that traditional beer by not using drums, which was supposed to, which support like the causing factor of having increased iron in that beer. Then they eliminate the consumption of that beer among the population and the community. So that's what we have on iron overload. For now, it's not really a problem in our setting, but the people we are seeing today are usually people with chronic anemia who has been transfused several times, but also, as I said, in a condition here, people are getting iron deficiency iron therapy for any case of anemia. They rush to give iron therapy for long time, so they come into the hospital with an overload. But also remember, people with hemolytic anemia, when you transfuse people with hemolytic anemia and you give iron, so again, they are using the iron which is coming from the hemolysis. So again, you see that they also having risk of getting iron overload. So that is all for white cells, red cells, and so on. We are going to now to start on disorder of coagulation, which will be very quick, and it's also a large one. But as we don't have enough time, I will just give the big titles. Then we'll be discussing later. So coagulation, I think it's just a matter of reminding you about normal coagulation. Big part of coagulation have been studied more in physiology. So it's just sitting on what is abnormal in coagulation. So we have abnormality of coagulation. So we make sure that coagulation cascade is only activated when there's injury. When there's no injury, when it activated when there's injury, that's where you may see people are developing a blood clot or so on. Then after the coagulation process, we have also to make sure that there is a fibrinolysis. So by this, you have to understand the function of the element which are involved in controlling bleeding, but also we have to explain the phase of coagulation, to describe to know what are the tests to assess the coagulation or to assess the hemostasis, or someone with bleeding disorder, what are the tests to request and how do you expect them to be. But also you have to describe the common clinical manifestation of disturbance in hemostasis, either bleeding or clotting. Those is the purpose of the presentation. So start by hemostasis, which is the stoppage of blood flow. This has three hemostatic components. We have three things which play a role here. We have extravascular. We have the tissue surrounding the blood will be involved in the hemostasis, where they'll be providing back pressure by swelling and trapping. So there'll be construction on the site of injury. So these are the first thing to intervene when there is injury. So second one have vascular. That's why also the quality, the size, the amount of smooth muscles, and the integrity of the endothelial cell should be also invoked here. Then the third level is intravascular, where we have to have a good number, good function of the platelets, but also good number of plasma protein, which are coagulation factors. But also we have to see when the fibrinolysis, what will be going on. So this is the first So under normal condition, we have the formation, the dissolution of thrombite is maintained in delicate balance. If there is any disturbance in that, the patient may have either risk of bleeding or having risk of thrombosis. So then by coagulation, we understand the process by which on vessel injury, the plasma protein together with tissue factors and calcium interact together on the surface of platelet to form fibrin clot. Then platelet is the one starting by providing a surfaces on for the coagulation reaction. So we have two steps. We have a phase one, which is primary phase, which involved platelet and vascular response to the injury. Then secondary, we have involvement of the coagulation factor because the primary hemostasis is not able to stop the bleeding. So together, platelets and coagulation factor will be combined, and the end of the process is to form a stub fibrin platelet plug, which will stop the bleeding. So to have a normal hemostasis, we have to consider all the factors involved in the primary and secondary hemostasis, which is integrity of small blood vessels. If someone is having vasculitis, again, as the vessels are not the vessels are fragilized, that may expose the patient to have bleeding. You should consider the number of the platelet, which should be adequate, not only the number, but the function. We have seen patient with the normal or increased platelet count, but having platelet dysfunction. So again, number and function of the platelet should be considered. Number and function of the platelet should be considered. Number of coagulation factors should be okay. Number of coagulation, physiological coagulation inhibitors like protein C, protein S, thrombodilium, all these should be really present and in a good number, but also need adequate number of calcium in the blood. So the vessels, we have seen the quality of the vessels, we have seen the platelet adequate in number and in function, because they are the one which will be accumulating and adhere to the site of injury. So here again, give me a few minutes. Sorry. Hello? Yes? Yes. Rayama na dusajja mbu they should send it to you babakohereje. Can you call them ukababwira? Niba batabiguha ubyohereze kwa Innocent bo they will send themselves. Merci. Sorry, so this is the blood flow going through the blood vessels. So here we have outside we have subendothelial cell and endothelial cell here. We have inside we have platelets and coagulation factor, and this is a normal condition. Then here we have endothelial injury, where we see how the platelets is transported to the site of injury. So what's the molecule which transport the platelet, if you remember your physiology? Which factor is involved in transporting platelet to the site of injury? Do you remember? Do you remember which factor?
Is it chemokines?
Hmm? Which one?
I think it's von Willebrand.
Yes, very good. So von Willebrand will be platelets and facilitating the adhesion to the site of injury. So here we have So after that, we need to have a fibrinolysis. Then the blood flow are repaired. Everything is repaired, and the life continue. So from the sides, we have blood vessels, which will be playing the role in contraction, dilatation. Then they'll be controlling, which are controlled by the smooth muscles. That's how when you get the injury, you can make even pressure, and that help also to control the blood flow. There'll be vasoconstriction with dilatation, which mean controlling the blood flow. There'll be also the substance which are released by the endothelial cells, which also contribute to the prevention of abnormal formation of the clot. So again, the inhibition of the coagulation is somehow from the beginning, from the site there. There is a secretion of nitric oxides, which really prevent those activation of coagulation process. So we have platelets. Again, the survival time of the platelet is 10 days. After 10 days, they are removed by the macrophages in the spleen. They are they are coming from the fragmentation of the megakaryocytes from the bone marrow. Then the role of the platelet is to plug in the vessel wall, but also it liberates vasoconstrictor, which will cause platelet to aggregate. This is usually in. Then it also releases phospholipid that initiates the coagulation. So quickly, this is primary. I've said it. Local vasoconstriction and platelet plaque. We have coagulation cascade and fibrinolysis. The details, I think you had it already. Maybe you can just jump some of the things. You have seen the cascade of coagulation. We have intrasec pathway and extrinsic pathway. We should also know which factors is involved in the intrasec pathway. So who can tell us which factor are in the intrasec pathway?
Factor 7.
There's we can start
Intras. So
factor 12,
factor 12.
intrinsic, factor 11,
Yes. 12. Yes.
factor 9 and 8,
Yeah.
factor 10, then
Mm-hmm.
common. From the factor 12, 11, 9, and 8, they are intrinsic to reach to the factor 10, which is the common pathway.
Yes. Then, but what about the intrasec?
Extrinsic. Extrinsic
Yeah.
from tissue factor, which is factor 3, factor 7, and factor 5. I don't.
Yeah.
No, factor 5, yes, allowed. To reach to the
So
factor
factor
10, which
5 and 2
contain
are in the
vasocommon.
common pathway. Yes.
Okay.
Thank. That's very clear. That's correct. Thank you. So again, the last step is conversion of fibrinogen to fibrin. Then what about factor 13? What
Factor
is factor
13 is
13?
one. Yes, factor 14 is one which make a cross-link of the fibrin that made at end product of coagulation. To make like a more stable.
That's correct. So if you understand all, so it make strong the fibrin molecular together. With that will be end of the coagulation. So that's what you're saying. So if you want to remind this, you have to start by factor 10, 12. 11, you jump from 11 to 9, then tissue factor is factor 3. You say factor 3 plus 7 is 10. 10 it is in the middle. Then thrombin is factor 2, so 2 and 5 times 2 is 10. So that's how you can remind, you can remember the factors which is either in intrasect or extrasect pathway. But also remember in the laboratory there'll be a specific test which will be assessing either intersect pathway or extrinsic pathway. That will help you to know what is next if I found this text is not normal or so on. We have also to know what is factor K dependent factors, which is 2, 7, 9, and 10. But also we need to understand the fibrinolysis, which is should be done after uh, the coagulation. So we have degradation of the fibrin products, which is called D-dimer. D-dimer measurement will help you to know if there's a clot formation on your patient. So factor 8 is the extrahepatic origin. It's usually produced on the endothelial cells. So von Willebrand facilitates the adhesion of the platelet to the surface collagen, but also it carries factor 8 of coagulation. So that's why, for example, in case of hemophilia A, von Willebrand, when it is severe, you may also see deficiency in factor 8, which is involved in hemophilia A. Apart that, we should also know the physiological inhibitor of coagulation, which is antithrombin 3. We have activated protein C and S. We have some mutation on factor 5, which we call factor 5 Leiden. So when there is a mutation in factor 5 Leiden, it makes it not active. It not respond to the activated protein C, so it not respond on the effect of protein C. So we have also trimodium, which are also part of inhibitors. So this is type of summarize the name of each factor and its function. Here we have also each factor in plasma concentration. That's why we see if your patient is needing a coagulation factors, the things to transfuse is to give plasma concentrate. So the abnormalities of a blood coagulation should raise from the things which are normal condition. Example, for this we understand blood vessels, platelets, plasma coagulation factor, but also we can see some cases liberation of the thromboplastic material in the circulation. So abnormality will raise from this element we have said. So let's say by the abnormalities of the small blood vessels, we are talking about the vasculitis. Then from the platelets, we may see decrease in platelet production, especially when there is a disease of bone marrow intrathecalemus in case of aplastic anemia, any bone marrow failure to produce the platelets, infection, and so on. That will be the issue with the production. Then we have also sometime there'll be bone marrow infiltration by leukemic cells or other cells causing decrease in megakaryocytes. Nextly, we'll talk about ITP, which is immune thrombocytopenic purpura, where will be it's in the context of autoimmune diseases where you have platelets. The patient have antibodies which will be destroying his own platelets and making him weak, which is somehow similar to the autoimmune hemolytic anemia. So we should know the should also understand that the the abnormality the bleeding due to platelet disorder are usually mucocutaneous. So the patient may present by small red blue spot, which is classified as petechia. They also we have different description of petechia. Those are petechia. Then you may also see patient with a large hemorrhage in hematoma, especially in the joint. These are usually associated with the plasma coagulation factor deficiency. Then we should also talk about hemophilia, which is hereditary condition where we have hemophilia A deficiency in factor 8 and hemophilia B deficiency in factor 9. But sometimes they also talk about hemophilia C, which is not common, which is deficiency in factor 11. Adding to that, we have also von Willebrand diseases, which are really among the coagulation, among the bleeding disorder, which is common. So von Willebrand disease, it is from the Willebrand factor. It is a large protein molecule which is produced by the endothelial cells and help the platelet to adapt to the presence of injury. But also, as we said, it also transports factor 8 and maintain its normal. Uh, we have also efficiency in prothrombin factors, which require in the conversion of prothrombin to thrombin. Here again, we understand vitamin K dependent factors. Most of the factors are produced in the liver. We have vitamin K, which may be requiring synthesis of most of the factor, the four factor we have said it, but also we can have also vitamin K deficiency in case of intestinal. If you are using a lot of antibiotic, you destroy the intestinal flora, then you may develop also vitamin K deficiency. But also the diet and so on may also cause vitamin K deficiency. We can also remember to think about the medication the patient is taking. Patient under anticoagulant like warfarin, they may also have a future of bleeding if the doses are not adjusted, but also as complication. They may also have inadequate synthesis of vitamin K. We have said the use of prolonged antibiotic, inadequate absorption of vitamin K, but also in case of severe liver diseases, which may also cause decrease in factor production. Lastly, we have also talked about disseminated intravascular coagulation, which may be manifested by abnormal bleeding states, which usually there'll be activation of the coagulation due to diseases which is associated with shock, with the bacteria or extensive necrotic tissues. That will be liberation of a thromboplastic activity in the blood circulation that will be activating the coagulation. So for that, there'll be overconsumption of the platelets and the coagulation factors, which will be dropped quickly, but also there'll be activation of fibrinolysis to defend body from there'll be derangement of fibrinolysis. So the patient, because they don't longer they have consumed their platelets and coagulation, there'll be massive bleeding reported. So we have first said that activation of clotting mechanisms, we have thrombosis, we have clot lysis, which will cause consumption of platelets and clotting factors, causing hemorrhage. Clot lysis, so there'll be this is a fibrous thrombus in small vessels in the disseminated intravascular coagulation. So now let's talk quickly about the laboratory test to assess the bleeding disorder. So bleeding disorder, maybe I can summarize it in few words. What we need to understand, first of all, is to assess the vessels, smooth muscles of the vessels. This will be the one if it is okay. Remember, if there's any vasculitis or whatever. Second is to see the platelet disorder. It's either be thrombocytopenia, decrease in count, or platelet dysfunction. Thirdly, we have to consider coagulation factor deficiency. The most common deficiency is usually hemophilia A, hemophilia B, mostly von Willebrand diseases, which are the common among the inherited diseases. The bleeding disorder are seen. Then that is among the inherited, but also we have acquired diseases where we have among the list we have liver disease, we have vitamin K deficiency, and we also have deficiency in vitamin K. We have said it. So again, those are the big group of the diseases which may cause coagulation, may cause bleeding disorder. So when you are thinking about the bleeding disorder, you have some tests to screen for your patient. So first of all, starting by the blood sample. So you need to collect the blood in the citric sodic acid that will be the proper anticoagulation to protect all the coagulation factors involved. Then after taking the sample, you need to assess the full blood count, which is should be taken in the ADTR tube. That one will be assessing the platelet count. So you check if the platelet is normal or decreased. Then bleeding time usually it will help to assess the platelet function because you may have normal platelet count, but due to platelet dysfunction, you may have bleeding. So bleeding time assess the platelet function, but due to the fact that it's not very sensitive, someone may interpret it as they want. So you may just do it's no longer used. So there are some specialized machine which is called platelet function analyzer, which will give you how the platelet is aggregating, how the platelet is so it really show you all the details on that. Bleeding time usually monitor platelet function, but not really indicator because it's not reliable. Then it varies from each institution. I can say mine, you can tell yours, so it's really not consistent. So we have a test called partial thromboplastin time, which it assess the time it takes for the blood to clot, blood plasma to clot, to clot out the lipid substance added to the plasma, meaning it measure the intrasect and common pathway. It's really more sensitive to the deficiency in factor 8 and factor 9, but also factor 11 and factor 12. So again, among the bleeding disorder, the most common factor 8 and factor 12. So again, among the bleeding disorder, the most common factor 8 and factor 9. So quietly here, we see that hemophilia, the screening test for hemophilia is to do APTT, activated partial thermoplastin time. So the abnormal one is when the essential factor is below 15 to 30% of the normal values. So that meaning for you to have abnormality in this test, it means that your factors are below 30%. Above 30% to the normal range, the test might be normal. So that is the same test which was activated. Then the normal range is between 30 to 40 seconds. Uh, we have said it. It tests the intrastate and common pathway. It depends on all the coagulation factor except factor 7 and factor 13. So factor 13 may come with normal APTT because it's really at the end of the coagulation process. It also monitor patient with heparin, but also it is screening test for hemophilia. Nusanga munafite APTT is normal. Really, hemophilia is not among the tests to be assessed. So next is prothrombin time. It's usually tissue thrombolysis factor 3. It's the test the sample mix the solid extra, the calcium to the sample, and they calculate the see they determine the clotting time. It usually help to detect the instance pathway. Mostly it assess the warfarin therapy when you are giving warfarin to your patient. Your focus test will be to test for the PT. It's from the PT that you can get also the ENR. So it's more sensitive to the alteration of the factor 11, factor 7, sorry. Then it is prolonged when the factor is 55% below the normal range. So it also assess the antithrombotic activity, and there'll be reduction in factor 2 and 10 after several days. So it's not really things to so. So it tests the instance in common pathway. Usually measure the vitamin K dependent factors, factor 2, 7, 9, and 10. It assess the normal value is between 11 to 15. Then we have ENR, which is reported as 0.8 to 1.2 as normal. Then how do you get the ENR? It's just you get the patient's PT, you divide by the control PT, which give you a normal range or 0.8 to 1.2. Then one patient is getting warfarin or coumadin, the target range is between 2 to 3. So it's a key test to assess your patient when you are giving vitamin K antagonist warfarin. So when the number is above 3, you have to decrease the dose. When it is around increasing, then sometimes to avoid the risk of the bleeding, you should be stopping the warfarin. When the count is below 2, you have to increase the dose. So it helps you to indicate which dose to adjust to your patient and to do follow up so that you avoid the risk of bleeding on your patient. When it is raising, meaning that there is risk of bleeding, again you have to adjust the dose of warfarin. Next one is thrombin time, which is thrombin is added to the plasma. Then they assess the time required for the clot to formation, and that assess the rate of at which fibrin will form. So usually this one is assessing the rate of fibrinogen in the body, but also if there is any fibrinogen in bitters. So it can be prolonged if the patient is taking heparin, if there is decrease in fibrinogen or in chronic liver disease. The normal range is between 13 to 20. Then it measure the second and the third line, third phase of coagulation. So these are a few exercises we have started. It's that like 55 years old female which admitted for a severe bacterial pneumonia, Staphylococcus aureus. He has pus in the left pleural cavity. He was given antibiotics. So the physical examination, he has a severe nausea and vomiting, the bleeding noted from the rectum and from the urinary tract, tissue extraction of treatment. After the prolongation of PTT and PT, so the both tests are all affected. So they're asking which phase of coagulation is mostly affected and what do you think is the diagnosis in this patient? But the question. Any idea? What is the diagnosis on this patient? Yes, we are
I
listening.
think I think it is secondary hemostasis, which is being impaired. Secondary
Mm-hmm.
hemostasis. The reason why is that we have seen that PTT.
What the diagnosis? Hmm? You say?
The diagnosis might be the lack of
Yeah.
factors involved in coagulation cascade, uh, um, both in intrinsic pathway and extrinsic pathway. Those factors which are involved in coagulation cascade.
The question is after seeing the case, what do you think is the diagnosis of the patient? What is
Probably vitamin K deficiency.
hmm?
Vitamin K deficiency.
Vitamin K deficiency really? Look at the condition the patient has.
They have DIC.
So the patient is having disseminated intravascular coagulation with the risk factor having severe infection. The story have a pneumonia with pus, giving antibiotic, has been severe vomiting, unable to drink, and so on. Then he's bleeding from the rectum and so on. So probably the patient having a DIC. Okay. The next one. So in DIC again, DIC, there'll be consumption of all factors. That means prolongation of factors in intrasec and intersec pathway at the same time. So that's why you see those tests are all prolonged. Make it clear. So that was an overview of bleeding disorder and what tests to do it. But again, we have a huge chapter, and maybe let's show you how you can see it now. Let me show you. So on this one, we are going to discuss about the platelets, disorder of the platelets. Normally, the platelet count is normal when it is between 150 to 400 per time 910. One is blood, thrombocytopenia. Then among the causes, there are two mechanisms. Either there's a increased destruction or there's decreased production. So we start by increased destruction, where we can see in immune condition where we have autoimmune thrombocytopenic purpura, which is also a common condition in our setting. You'll be meeting the case of ITP. So this immune can be associated with other immune diseases like lupus. We can also see in case of malaria, CLL, or lymphoma. It may also be due to drug-induced, due to quinine, heparin, or maintenance immunization. We have also a non-immune one, increase the screen in one non-immune one in case of DIC, TTP, or giant hemangioma. So we increase production, especially part of the bone marrow failure, unable to produce the platelets, and then of exposure to toxicity. to radiation in case of leukemia, myelofibrosis, multiple myeloma. So all these blood hematological malignancy can cause deficiency or decrease production of the platelet. So we can also have abnormal platelet distribution in case of hypersplenism, where there will be destruction of the platelet before the lifespan. We can also have what we call delusional anemia in case of massive blood transfusion. It does also occur. Platelets are there, but the patient has received massive blood transfusion. That's why it advised when you are giving a massive blood transfusion, you should also giving platelet transfusion. There is a protocol on massive blood transfusion to be shared. So drug induced usually causing immune mechanisms. These are the list of the medication which may cause immune destruction of the platelet. So for the autoimmune thrombocytopenic purpura or ITP, the mechanism is in disorder that the autoantibody or immune complex are binding to the platelets and cause their premature destruction. To respond to this, there will be increased production of megakaryocytes in the bone marrow. Then for ITP, we have two forms. We have acute and chronic. So more acute ITP, we have immune complexes of the viral antigen and also antiviral antibodies. They're binding to the platelet receptors and they lead to immune destruction of the platelets by the macrophages in the spleen. So again, acute ITP, when you go deep in the history, you may ask the patient, he may say, okay, like in 2 weeks before, I had fever, I had flu. So it's somehow following the infection, viral infection. Usually there's a peak. It may also occur after vaccination or in viral infection. The peak is between 2 to 7 years, but there is no difference between male and female. We say that for the platelet issues, you have bleeding from the mucocutaneous to the purpura, petechia, and so on. They may have splenic enlargement, which is not usual. And usually, acute ITP may be spontaneous self-limiting diseases with remission between 2 to 6 weeks in 80% of the cases. But sometimes this thrombocytopenic and persist up to 6 months. We call it chronic ITP. So the mortality and morbidity related to acute ITP is somehow low. So the chronic ITP, the antibodies are usually like GP2B, 31, and GPB on the receptor of the platelets. Then the antibody-coated platelets are now recognized by the FC receptors on the macrophages, and then they're also destroyed in the spleen. So the mechanism about the chronic ITP, it's not known. So how does the symptom present? The patient will present to you with either with or non-history of a prevalent illness. It usually affects the young adults between 15 to 40 years. Females are the most common having the symptoms. Then again, they will have mucocutaneous bleeding, bruising, petechia, chronic or whatever. Due to chronic bleeding, the deficiency, but also they don't have splenomegaly. If you have splenomegaly, you have to consider other diagnoses. We have also they may also have association with other autoimmune diseases like HIV, lupus, lymphoma, autoimmune hemolytic anemia coming in the context of autoimmune diseases. The spontaneous remission is very rare compared to the acute ITP. So what will be the diagnosis of ITP? The platelet count will be mostly reduced below 20 in acute one, but in the chronic one, it will be like around 50 and up. So it will be the diagnostic of ITP. How do you make the diagnosis of ITP? You will see on the peripheral blood film where you see megathrombocytes, which we call large platelets or giant platelets, platelets which are large in size, but also we can also exclude other causes of thrombocytopenia, which include aplastic leukemias, and so on. For the bone marrow, you'll go to the bone marrow, you'll be targeting the megakaryocytes, which will be either normal or increased. The bone marrow is full of megakaryocytes, but it's just the issue with destruction. So the megakaryocyte may be also hypogranular or hypogranularity. So they have uh, future of this future of accelerated platelets, which we can separate from the platelets. Let's say if my patient is having ITP, if I want to make the difference between ITP with someone with, let's say, leukemia, someone with decreased platelet due to leukemia or due to production, with someone having thrombocytopenia due to destruction. So if I have ITP, how can I test it? I just go for the platelet transfusion. When I transfuse the patient, immediately I check the platelet count. It should be increased. Then, if I check later on after 1 hour, 2 hours, there will be drop in platelet immediately. So the antibody again destroyed the new platelet transfuse. But someone with the issues with the production, when you're transfusing, I'm expecting the platelet transfuse may spend around 7 days. So the patient will keep the transfused platelets for a while. We can do the control later and find that the platelet are still there. So that means for ITP, really, we don't need to transfuse the platelets except if there's major bleeding because the high consumption of the platelets. So as for the acute ITP, there's therefore you don't need to transfuse the patient. If 30 is there without bleeding, you don't need to transfuse the patient. In children, when the platelet is below 20, you can give oral corticosteroids or immunoglobulin. Those are targeting to decrease the production of those antibodies. You can also give platelet transfusion, but again, it does not help because the platelet transfuse are destroyed quickly. Chronic RTP, when the platelet is above 50, you don't need any treatment. If the platelet is below 30, that's when you start putting the patient on the treatment, and you gradually divide the dose after 15 to 40, 10 to 15 days. That's when you start decreasing the dose. So mode of action of this corticoid is the suppression of the phagocytosis of the antibody-coated platelets by macrophage and the suppression of antibody formation. So if there's poor, normally we have first line, we have second line, we have a third line therapy. So the first line therapy is starting by giving corticoid. If it does not work, you go to more aggressive immunosuppressors, which are now being either rituximab, but also you can give some immunosuppressants. If it does not work, you go for the third line, which is giving splenectomy. Splenectomy is only done if there is poor response to the previous treatment. So those immunoglobulin is usually given because it gives quick response in raising the platelet, but the action is very short, but also it's really very expensive. Getting the dose one day it may cost like 3 million. So again, that's why it's not given routinely, considering that cause, but also the impact on that. So that is what we are saying. You can give IV immunoglobulin for 2 days. Then you can also give other immunosuppressants. So platelet transfusion again can be beneficial if there's acute life-threatening bleeding, but not beneficial only for some hours. As I told you, when you give the transfusion, the patient get it, but after a few hours, it really destroys. You need to spare platelets. Secondly, apart the coagulation, we have apart the platelets, we have coagulation disorders, which is we have hemophilia, which is hemophilia A, factor 8 deficiency, hemophilia B, factor 9 deficiency, and you have von Willebrand disease. So I don't want to skip this chapter, it's because we are having partners willing to support hemophilia. They are doing advocacy among medical doctors, health providers to have awareness on the diagnosis of hemophilia and to refer the patient earlier for diagnostic and know how to manage the case of hemophilia. So that's why I'm going to insist a little bit on hemophilia. Uh, we have it's inherited long life single clotting factor deficiency, where we have hemophilia A. It's the most common, representing 85% of hemophilia. Now 13% are hemophilia B, deficiency in factor 9. It was called Christmas disease because the patient who has it for the first time is called Stefan Christmas. Then it also published in the Christmas edition. That's why they call it Christmas disease. We have rare case of hemophilia C, which is deficiency in factor 11. So by this, only female male are affected, but female are carriers. But recently, we are also we are also have future of acquired hemophilia, where even female can get the disease, and we have seen a female bleeding from the. She went for the surgery. She had an ENT issue, and she went for surgery. From the surgery, she was bleeding a lot, so no one could imagine that a girl can have hemophilia. It's just when we went to test this basic test PT. APTT was very prolonged. Then among key assess when you have prolongation of APT, you have to think about hemophilia. So when the test factor 8, it was really very low. So that we start her on factor 8 therapy, and she gets well. So that was like a rare case of hemophilia in female. So hemophilia 8, the most common of the encoding factor deficiency, the prevalence is 30 to hundreds per million of population. In Rwanda here, so far we have diagnosed around 80 cases, 80 cases, but I think this is underestimated. It's just because there's the diagnostic capacity is still low across the country. So some cases which are not yet diagnosed. So here again, if the country have around 13 million, so we are maybe expecting like over 13 million. We may expect like 3,000 maybe. I don't know. Yeah, the number should be higher. Then it's a X link, sex link. It's on the chromosome X, but also in terms of 33% of the case, you may not have family history of hemophilia. So the factor 8 gene is situated near the tip of the long arm of the chromosome X, which has large and consists of 26 exons. So the deficiency may either be absence or low level of plasma factor 8. So how does the patient present? The patient presents a profuse bleeding. Depending on the severity of the hemophilia, we have classified hemophilia, mild hemophilia, moderate hemophilia, severe hemophilia, depending on the level of the factor. So the bleeding pattern depends on the severity of hemophilia. People, maybe I can just summarize. A mild hemophilia, when it is above 5, then 5 to 2, that is moderate, then below 2, it is really a severe hemophilia. So people with hemophilia, they may spend their life without any bleeding, except if they get injury. We may go in the side on the surgery for the first time. Then when you go to surgery, that's when you realize that the patient is hemophilic. That's bleeding. But the one with severe hemophilia, those are the patients who may even bleed spontaneously without any injury. So again, that's why I'm saying the clinical severity depends on the disease correlation with the factor 8 levels. So operative and traumatic hemorrhage are life-threatening both in severe and middle affected individuals. So being hemophilia, you can raise the risk of bleeding. So those patients may bleed from the circumcision if the first time of circumcision, but also the site of bleeding are usually deep, like joints, soft tissue. They may have hematolosis causing bone deformity, and so on. They may also having a spontaneous intercerebral hemorrhage, depending on the severity of the disease. We may also have hemophilia pseudotumor, which may develop in long bones, but also they may have a bone destruction and have pathological fractures because they have that's accumulation of the blood on the joints, on the bone, and so on. So the hallmark is the bleeding into the joint and muscles. They may also have bleeding on the nose, immaturity, but also remember to screen for the family members because sometimes they have family history. So there's a history of hemophilia in European royalty in the past, where the British Queen Victoria had fear. Two of our doctors had hemophilia. Then those doctors got married to royal houses across the continent, Spain, Germany, and Russia. Then the press disease. So classification of the bleeding, you should also know if it is the bleeding this one from the gum, epistaxis, and so on. Major bleeding from intracranial, neck, or major injury, or advanced hematosis. The diagnosis is usually made by the basic tests when you find the prolongation of APTT. Then if APT is prolonged, you measure factor 8 factors, which will be low. Then bleeding time and time will be normal. But you can also take the tests if you are suspecting family history of hemophilia. The test can be taken from the um, from the 10 weeks of gestation, where they get the chorionic biopsy and they make the dosage of factor 8, then you can make the diagnosis. From 16 to 20 weeks, you can get the sample from the umbilical vein, and you do needle guided aspiration of the sample, and you get it from the measurement of the factor 8. So here again, we have said about severity. Below 2% it's severe. Below between 2 and 5 is the moderate, and above 5 is milder. Depending on the categories, that will explain how will be the frequency of the bleeding. Occasional bleeding from the mild, usually after severe trauma or surgery. Then for the severe one, they have a traumatic or spontaneous bleeding. So again, that will help to differentiate. So how do we treat it? Now the treatment is somehow improving. In the past, we could not have access to the factor 8, but now with the support from the World Federation of Hemophilia, we are getting factor 8. So all the patients who are non-hemophilic, who are registered, are able to get the factors. So actually, the site of factor are usually at Siashika, but if the patient is living far, we prescribe the factor, and the factor can go with the factor at his home or nearest hospital or say health center or whatever. So, but in before when you don't have factor 8, what you need to do, you can give a cryoprecipitate, but also if you don't have cryoprecipitate, you can also give the plasma, but this is not really indicated. There's another molecule which is called DDAVP, which is desmopressin. Desmopressin provide also an alternative for increasing plasma factor for the male hemophilic. So it somehow substitute the factor 8 from the reserve storage to be available to be used in the blood. So you can give it when you don't have available factor 8 replacement. So people may also need prophylaxis in case of severe hemophilia, where they may like preventing massive bleeding on those hemophilic patients. So after getting the factor for long term, people may develop also antibodies to factor hemophilia. Then if there's risk of hemophilia, the patient may develop antibodies to factor 8. So that will be the worst condition where you'll be giving factor to the patient, and the patient may quickly destroy the factors. So in that time, you can consider giving immunosuppressants to these patients. This complication include deformity due to joint arthropathy. They may develop inhibitors, which are said may come against the replacement factor. Then that will be again ineffective to give factor 8. The risk factor is usually family history of hemophilia, but also black severe hemophilia. Then we have to test for inhibitor every 6 months before any procedures. But also, if there's no response to the factor replacement, you have to check if the patient has not yet developed factor inhibitor. We also consider to give the risk of infection because risk of blood products, so transmission of hepatitis, HIV, and so on. Definitive treatment is to raise the factor 8 or 9, depending on which of the hemophilia, by IV replacements when the patient is having severe bleeding, but also the patient should be educated how to get injection of the factor from home. Most of them knows how to get the nurse teach them how to get the factor injection. For the replacement, we may use primary prophylaxis to prevent bleeding from neonatal period, lifelong, or before any bleed happen. That is the primary one. Then we can also give treatment on demand. if there is a injury or before procedures. So if hemophilic patient is going to get operation, you have to make sure that the factor are in the normal range. You have to give him factors before surgery. Secondary prophylaxis, it's just regular replacement in case of joint pain, or some people who may have already developed intracranial bleeding on severe hemophilia. They need like secondary prevention of other bleeding. So management of bleeding episode, if the patient come to you with severe bleeding on known with hemophilia, you're supposed to treat without waiting to test first the factor. You don't need to check the factor first. We have to give 40 unit per kg. You take it in intravenous. Then you state the patient as if possible, if indicated. Then if the bleeding is minor, you can give 20 unit per kg. You have to relieve the pain. You have to rest, and ice pack concentrate should be there 5 on 10, 5 on 9, and you keep the patient and elevating the factors. So general management insists on the not it's a chronic disease with the not it's chronic disease not curable for now. For in a setting, you need to do counseling and education of the family members, the patient education. You have to inform the school that the patient is hemophilic so that he can avoid some non contact sports. So you have to do non contact sport. They have to do genetic counseling, medical alerts. Some of them they have their cards so that they can move with their cards everywhere. Patients should be educated about informing the doctor when they are planning for surgery. The doctor should be screening for hemophilia. The dentist, the orthopedic surgeon, genetician. So this is really a multidisciplinary team to take care of those hemophilic patients, because I said they may have bone deformity, joint deformity, they may have teeth issues, they may have may needs physiotherapy. So really, it many people should be involved in that management. So in management, you should be avoiding risk of bleeding by avoiding use of aspirin and non-steroid inflammatory drug. They should be having immunization against hepatitis A and B. Then, in case of mild hemophilia A, they may use the vasopressin, which release factor 8 from the storage. But also, if there is a mucous membrane bleeding, they may use also antifibrinolytic when you cannot get easily the factor replacement. But now on the ground, they're now doing gene therapy in different countries. It's still early to say if it is working or not, so it's still under experimentation. Surgical management, you need to replacement before and post operation. So if the patient is hemophilic, you need first to stabilize. If it is not urgent surgery, the patient should come to the hospital. You check the level of the factor. You give him the factor. You check again. Then the patient go to the surgery where you have normal PT and you are targeting the type of surgery. If it is a major surgery, you have to give the patient factor up till they get 100% factor. So that's again thing to consider. Then the surgery should be done with very skilled doctors, like surgeon with the support from hematology team together. That's how we may manage the risk of bleeding. So hemophilia B, it's somehow similar in the clinical manifestation as hemophilia A. You cannot distinguish them physically, but what we need to know is that they are less frequent. They are like 15% of the cases. Then the difference is just when you measure the factors. For here, factor 8 will be okay, but when you measure factor 9, that's when you find that this is hemophilia B, not hemophilia A. So just to recap, just to say that the factor 9 is somehow having a longer biological half-life, you can give this less frequent as factor 8 concentrate. The next one is vulnerable diseases. We have talked about vulnerable diseases. We have said its role in promoting platelet adhesion to the damaged endothelium, also carrier of the molecule of factor 8. Vulnerable disease is the most common inherited bleeding disorder. This is now in term of inheritance of autosomal dominant. So it's somehow most common with the prevalence of 1%. It affects male and female the same way. The deficiency might be qualitative defect of vulnerable bone. It may be congenital or acquired, but the acquired one are very rare. So the clinical manifestation depend on the subtypes of vulnerable bone. So we have this is the molecule here. So they are there to the damaged subdural matrix by activating and recruiting factors, platelets, but also promote formation and platelet plug. This is the original. It's somewhat playing role in the primary hemostasis, but also as it carry the platelet, it functions also in the secondary hemostasis. So binding to factor 8, it all then plays also in the secondary hemostasis. So binding to factor 8, I've said it. This is table you see there. It's really give you detail on the subtype of von Willebrand from type 1 to type 3. Depending on the type 3, that's when you may see, for example, in type 3. That's why the effect of factor 8 will be markedly affected. So in fact, factor 2M, factor 8 is normal or decreased, but in type 3, that's where the factor will be really affected. So my type 1 is the most common with mid to moderate deficiency. It usually have a normal von Willebrand function. It's also autosomal dominant. And for now, it is not easy to make the diagnosis because the patient with only mild deficiency or borderline deficiency, they may not have any evidence of bleeding. We have type 2, which is now dysfunctioning one vulnerable bone. They can be transmitted either auto recessive or dominant, depending on that. Then it also classify you different type of abnormality. You go in details. Then we have also acquired one, which may be seen in association with either hypothyroidism, lymphoma, and so on. So they present at any age, but they have future for mucocutaneous bleeding patterns with the bleeding from the skin, from the epistaxis, and so on. It usually missed on the female. Most of the female usually present with a prolonged messes. You can send the patient to the gynecologist. They do all the exam, but the messes are really very prolonged. So think about von Willebrand and screen it for that. If they don't find any cause of menorrhagia in female, they're having heavy messes. During pregnancy, there will be increased level of factor 8 and factor von Willebrand, which are doubling at the time. So it's not easy to diagnose during pregnancy, but it usually fell down after delivery. So type 3 can be bleeding like hemophilia because they have a decreased factor 8 factor 8 deficiency. The patient, as we said, will have mucocutaneous bleeding. But if the patient, you have to screen also other cause of bleeding like leukemias and so on. So lab investigation is usually normal. FBC is normal. The patient, due to chronic bleeding, they develop iron deficiency anemia, so they may have microcytic hypochromic anemia. When the bleeding is recent, they may have just monocytic pneumochromic anemia, but in subtype 2B, they may also have thrombocytopenia. When you go to the laboratory, that is something somehow strange. In von Willebrand disease, you find normal ITP, normal TTP, you saw normal PT, which is normal ENR, but also APTT may be normal or prolonged. Being in them will be normal or prolonged, so meaning that if you are suspecting von Willebrand disease, you may find the patient with having normal bleeding time, normal PT, and normal APTT. So you still need to go further and measure von Willebrand activity. So all lab tests might be normal, but if you suggest the history is suggesting von Willebrand disease, you have to request definitive tests. Definitive test is usually to assess the resultating induced platelet aggregation, which will be assessing the activity of von Willebrand, but also it assess the von Willebrand collagen binding capacity, and the analysis is began to assess the gene analysis to see if there's any mutation. General management again, it's like hemophilia. You have to educate the patient. You have to inform the school to avoid something which is the same as the past group. Contact spore, follow up of the blood products, and so on. Team approach by dentists, physio as the first group. So educate the patient about management of the bleeding from home. So how they can use the local hemostatic agent, how can they use the local hemostatic agent, how can they use the nasal package, because really it's a chronic issues. It may not be easy to rush to the hospital every time the patient having few symptoms. So we can also have vasopressin. We said that vasopressin usually release factor 8 and von Willebrand from the storage tissue. It will cause mild activate of the platelets, and it can be used in type 1 and type 2. So it can also be used in type 1 and type 2. So it can also give in. If there is a von Willebrand associated with hemophilia, you have also to give factor 8, but also you have a recombinant of factor von Willebrand, which is available but really very not really expensive, where even in Rwanda we don't have one. So meanwhile, you can also give antifibrinolytic drug like tranexamic acid. For menorrhagia, you can give oral contraceptive, or also you can also give desmopressin. So von Willebrand disease, it's really common, but sometimes we deal with the diagnosis which is not done. Laboratory, I think you've mentioned it. That was a repetition. So that is really the commonest inherited diseases we have of bleeding. So we have hemophilia and von Willebrand disease. The rest you may be, which is not frequent, don't have impact on. They may have clinical manifestation, but they're really very rare, but not common. Among the acquired, maybe I'm not going into more details. Understand intravascular coagulation, disseminated intravascular coagulation, vitamin K deficiency, and liver disease are the most common of acquired bleeding disorder, where you should be screening for the causes. Remember that liver is the site of production of the coagulation factor, except factor 8. The rest will be affected if there is liver diseases. Then, among the treatments, you have to consider giving plasma transfusion as plasma contain coagulation factors. Remember also vitamin K dependent, so bleeding disorder, vitamin K deficiency, and so on. So you'll have to read on that. And again, remember that DSC is not a diagnosis, it's just due to underlying diseases. We have said about activation of coagulation system without injury, just because there is a liberation of tissue factor in the bloodstream that will cause bleeding. consumption of the coagulation factor in the platelet, which lead to bleeding disorder, bleeding, but also they'll be leading to fibrin deposition, causing microvascular thrombi in various contexts. So what we can also see in DC, it just the origin can be due to factors which is triggered by tissue factor. So there will be liberation of the tissue factor in the bloodstream. So tissue factor are expressed in the leukocytes, circulating also leukocyte, but also are expressed on endothelial cells, but also in the cytokine, especially when there is a tissue damage or there is inflammation, that will be release the cytokine. So again, those are the factors which may also contribute to the DIC. But also we also understand that there is also inhibition of coagulation, where the thrombin is decreased. We have protein C, protein C and protein S decrease, but also tissue factor inhibitor pathway is also decreased. Those are the key things to consider when there is a DIC. So you have to read it deeply. The mortality is high, so it occur at any age, any class, and any gender. Then the risk factor are here listed, especially sepsis, severe trauma, malignancy, obstetrical condition. So any of the condition may increase the risk of having DIC. So the list is exhaustive. You can also have it. This is the symptom. So how do you make the diagnosis? Suspecting on it at any fact in patient who's very sick, but also you can also use some laboratory tests at among the laboratory tests to test, you have to test for the full blood count, which may show you decrease in platelets. It may show you when you go to the peripheral blood smear, there is a key element you have to consider, what we call schizocyte. Remember, I said that the schizocyte is a red blood cell fragment, which is due to mechanical damage to the red cell membrane. So in the DIC, there is a microthrombus, which may cause damage to the circulating red cell. So the image of schizocytes here, I can show here. This is a uh, red cell, which is called schizocyte. This is maybe seen in case of DIC or in case of TTP. Are you following? Oh, you are tired.
Yeah, sure. Very tired.
Tired.
Are you tired? Can
Yes,
you can you can you stop there and we might find another time in the future.
I can stop.
Yes, yes, would be good.
Hmm?
Can be good because we are no longer understanding for sure.
Yeah. So let's see if you can find time. So remember that PIT, disseminated intravascular coagulation, they are consumption of all the factors. So that means PT and APT will be affected. So all the factors are involved, but also fibrinogen may be not specific. Why? Because fibrinogen can increase in case of infection and case of inflammation, so that it's not really specific to assess the fibrinogen as the key one in case of DIC. We have D dimer, which is fibrinogen product will be increased in case of DIC. So among the treatment, let's just finish DIC. We have to consider treatment of the underlying condition, but also we have a supportive management by blood transfusion. We need to consider now the fresh frozen plasma, which contains most of the clotting factors. That's among the indication of giving FFP, but also consider cryoprecipitate, especially when you're targeting to increase fibrinogen level. So cryoprecipitate contain factor 8, factor von Willebrand, but also fibrinogen. So again, should be transfusing the patient. So vitamin K should be given in IV. Then also the patient, there is also problem because the patient also have protein C deficiency issue with the antithrombine. So again, the use of vitamin is somewhat controversial. So the prognosis depends on the underlying condition, but also when the condition is addressed, the coagulation profile should be normalizing. So that's all for DIC. Maybe we can find another and discuss on the remaining things. We just need to talk about liver disease, vitamin K, and blood transfusion. Those are 3 things remaining. If we can get 2 hours another session, that would be grateful. I will keep in touch with the CP, and to see if we can organize one session of just 2 hours to cover. But otherwise, I'm going to prepare all the thing and I share with you. Right? Any question on that? Any question? If there's no question, we can stop here and we continue next time. Hello?
Yes, hello.
See you next time. Then we should have like 2 hours extra and finish the course. Thank you. For tomorrow, you'll be covering immunology with my colleagues. So please be there and continue with immunology. As is not around, that's why we went on online. Usually, I should be start. It was planned that I start at Gako, then he cover Remira 2 days. Then he's supposed to go to Gako, then he come to Remira, but because he's not around, he's supposed to do it online. That also make me to combine the 2 classes online. We prefer really to have face-to-face discussion. That would be better, but we didn't have any choice. That's why the course has been done remotely. But hope that if you have any question during your rotation at Shika, I'm there. We'll meet again where we'll be rotating next year in internal medicine. So I'm head of internal medicine department. We'll meet again next year. So thank you so much. I wish you a nice evening. Keep in touch.
Nice evening too. See you.